Hello, SAGES community. I just want to take the opportunity to thank not only SAGES, but as well as the moderators for this opportunity to present to you today at this first ever virtual SAGES. I'm very excited to discuss with you our options for surgical technique that may be affecting postoperative pain after ventral hernia repair. What can we do to give our patients the best outcomes? I have no conflicts of interest and want to mention that my opinions are of my own and not those of the DoD or the United States Navy. So to start our discussion today in thinking, what do we already know and what have we known about what can affect postoperative outcomes of quality of life for ventral hernia repair, depending on what we do in the OR for our patients and what technique we're using, that we are tried and true to know we're doing well by our patients, but do we know that the long term we're still doing well, and what's the recent data tell us? I took a specific interest in this through my training and specialty training specifically in abdominal reconstruction, and wanted to answer a few questions of specifically different aspects of technique and how it affected this. Starting with mesh size, does the mesh to defect ratio have any factor on knowing that you're going to have an impact on quality of life after ventral hernia repair? So when looking at this, we consider, okay, if we take those larger mesh to defect ratios and we separate it out, open or laparoscopic, then divide it in 3 tertiles of small, medium, and large defects. Do then the mesh to defect ratios have an effect in those comparison groups? So we did not see an impact in pain or overall quality of life, independent of either approach. When you consider a small mesh to hernia defect ratio of mesh use, if it is a medium laparoscopic or large laparoscopic ventral hernia defect, if you're using a small mesh to defect ratio, it worsened the short and long-term pains and overall quality of life scores. However, the large open ventral hernias also had similar concerns. We then considered, is there any effect then on recurrence for this? And when you look at the mesh defect ratios of less than 4:1, it did have an impact on recurrence. So those larger open ventral hernias with a smaller amount of mesh to defect ratio did have a worse recurrence rate. Now, this may not be a consideration of quality of life for the long term. However, it really should be, considering most recurrences are identified from pain. And while this type of pain may not be picked up on a Carolina's Comfort Scale objective hernia specific assessment, it certainly can be a cause for pain that then leads to recurrence and is the fixation point for the patient. That does affect their overall quality of life. If you have any concerns about the consideration of mesh to defect ratio as being an objective rule for knowing how much mesh to use within your repairs, here's a list of predictive factors that were modeled in a recent publication in surgical endoscopy and include the historical and well-known mesh overlap consideration in comparison to these other factors. And the only predictive factor was found to be the mesh to defect ratio. So it is something of consideration for further publications to include this when describing how much mesh they're using in comparison to their hernia size. So then how about fixation? Dr. Belyansky published a great paper early on in his career stating laparoscopic inguinal hernia repairs and less than 10 tacks was really that cutoff for quality of life. I wanted to look at that similarly in ventral hernia repairs. So you see here the inclusion of the patients and their characteristics, and we wanted to look at those outcomes, not only of recurrence, but certainly of quality of life, utilizing the Carolina's Comfort Scale. We then used a goodness of fit assessment and model and performed internal validation. We then looked at open separately from laparoscopic ventral hernia repairs and identified that an open repair, suture fixation alone could not be protective for postoperative pain. It in fact was protective compared to those that would use tacks in combination within 6 months. However, anything at 1 year and beyond, there was no method of fixation that was affecting pain. This is in comparison to laparoscopic ventral hernia repairs, and we identified that less than 40 tacks was actually protective against short-term pain. However, this factor fell out of significance at a year and beyond on affecting long-term pain. But for those patients who come in and early on want to get back to work, which means money, and money is important for those patients to be able to work, then you need to consider your technique affecting those short-term outcomes alone. How about concomitant procedures? I couldn't identify any common procedures such as cholecystectomy, hysterectomy, solid organ excision, but there is a common procedure that's performed, although you may not consider it, such as enterotomy on those recurrent hernias. And does that actually affect the quality of life? And we identified that in fact it does. At 6 months, we've seen these within all these factors as seen here. However, the long-term 1 year and out, it didn't seem to. And this was independent of if the patient was getting a deep space infection from the enterotomy or any sequela from that, but just having had performed and repaired an enterotomy during the ventral hernia repair. So what does the new publication show? Is it in contrast? Is it collective in comparison? Does it prove what we've known in the past? And how are we changing our technique to keep up with the latest data? So how about surgical approach? Does our approach alone, open versus an MIS technique, does that need to be considered? Well, within the last year, there certainly has been, within the last few years, several publications on a particular practice to say, here's my open and here's my robotic techniques, but how about those randomized controlled trials? And Switzerland will be putting this out. They published a protocol this year, and we'll see something out on that on robotic versus open primary ventral hernia repairs. Well, what about consideration of any anesthetic injections, tap blocks? So certainly this can be performed preoperatively, intraoperatively, but we've known as it's been bundled in many ERAS projects that it is beneficial as a package to reducing our patients' postoperative pain and minimizing their need for narcotics. And that's certainly in contrast to epidurals really falling out of favor to have those outcomes. So this is really where we're leaning and pushing towards. The most recent publication this year on this is the transverse abdominis block in laparoscopic ventral hernia repairs with a group out of Germany. And this has been consistent with what we've known of randomized controlled trials published as early as 2015, and the same approach in patient population, that it reduces post-op pain and need for narcotics after surgery. How about component separation? Is there a different component separation that we should be doing on a consistency for the patients? This hasn't been looked at in certainly the last year of publications or any recent, the most recent dating back to 2017 on the effect of component separation affecting quality of life for open ventral hernia repairs, identifying actually that there was no difference in quality of life. However, there was found to be a difference in wound infection rates, minimizing this issue and complication after surgery when a transverse abdominis release was performed. And that was in consideration of control for hernia size. So while it is a wound complication factor, when you consider the patient having to come into the clinic to either get evaluated or perhaps treated for that wound infection, especially in the current era of minimizing trips to the office, it really can affect that patient's quality of life. How about fixation? We've seen, and I've discussed in the past, how that laparoscopic repair, the short term, you use less than 40 tacks, you're minimizing their initial postoperative pain. What do we see now? And Dr. Pujols has reported from the AHSQC on a propensity matched study of 3 to 1. If you have a hernia that's less than 15 centimeters and you're using permanent mesh, how do we compare that? Fixation versus no fixation. Do we need it in that retromuscular space? And what they identified was that fixation increased your pain scores in the early postoperative period, yet there was no difference in recurrent out to 3 years. As well, Dr. Hope's group looked at the AHSQC to identify the effects of fixation in laparoscopic ventral hernia repair. He compared tacks for sutures and the combination of such, and identified that in a tacks-only group, there's actually worse quality of life at 2 years. There wasn't identified any difference in quality of life at the earlier time points, which this data then did differ in that way than earlier data from the International Hernia Mesh Registry with similar question at hand. How about predicting and preventing pain then? What can we do if we're trying to minimize these surgical techniques as discussed? Is this really where the money is, or is the higher benefit to the patient, whether it be in counseling or your timing, which also can play a factor of surgical technique on timing of operation. So we put together a predictive model for chronic pain after ventral hernia repair. What we were able to conclude using our usual predictive model techniques is that at a month, consistency of unchangeable factors such as patient's young age and female gender remained consistent to show increased pain and worsened quality of life after ventral hernia repair. As well, and of importance, preoperative pain consistently was shown at 1 month, and I'll show you as it goes out to the long term. At this earlier time point, we also identified that there were surgical techniques, component separation, and postoperative complications that would occur. But the component separation was the only surgical technique at this time point that we identified was a factor. The long term, all the surgical technique factors dropped out of the algorithm, and consistently younger age and female gender stayed, as well as preoperative pain. In addition, that 1 month pain built into the 6 month model, and the 6 month postoperative pain elucidated out at the 1 year to be a factor of increasing risk of pain at that time point. As you see here, again, young age and female gender, those cannot be changed. When we consider preoperative pain, while that can't be changed as its course of action, it can change in our timing as we consider how can we help that next patient. So not only can we counsel the patients better, but we may be able to intervene earlier. So in conclusion, we should consider that preoperative pain can predict the postoperative pain, meaning here as we've shown a predictive risk model of that early pain, predicting the 1 year pain out, factors unchangeable, age and sex, factors to counsel the patient, is it a recurrent hernia? But as you look at that preoperative pain score, when we're able to drop that out of the algorithm or dropping it out of statistical significance for risking pain at 1 year. As well, when we gradient out that Carolina's comfort scale of preoperative pain, you can see that the more pain score they had preoperatively, the higher increased risk post-op pain at 12 months they had, meaning 5 for your CCS score, 10 times the likelihood of pain at 1 year after ventral hernia repair. So if we were able to operate on these patients sooner than when they have a lesser level of pain or perhaps no pain at all, and you know they'll inevitably need a repair, you should operate on them earlier to minimize their risk of postoperative pain, which is part of your surgical technique considerations. I want to thank you for the opportunity to present to you today, and I truly hope that you enjoy this venue of virtual SAGES as I have. Thank you.